Hi, and welcome to the Neurology Nook, where we dive deep into different topics of neurology, covering everything from Alzheimer's and stroke to the latest breakthroughs in research and technology. Hear inspiring patient stories, gain insight from top neurologists, and discover, most importantly, how to keep your own brain healthy. Welcome to the Neurology Nook. This is Kelly, and I'm with Dr. Modi today, and we have Sarita Maturu here with us on the podcast. She's an epileptologist from Ohio State University who did her residency with our very own Dr. Modi. So we're going to have her introduce herself, and we will get started. Thank you so much for coming on the podcast, Dr. Maturu.
Thank you so much for having me. Yeah, so my name is Sarita. I'm an associate professor at the Ohio State University Western Medical Center in Columbus. I've been an epileptologist here for the last 7 years, and it's been a really impactful journey here. So I see only epilepsy patients. My major passion is in women that have epilepsy and all kind of facets of their life. But I also work to develop neurology multidisciplinary and specialty clinics here. So we have about 27 different multidisciplinary clinics that span
Wow.
across all the divisions of the neurology department. So that's my other thing that I'm very excited about.
Oh, that's incredible. 27 different specialties within neurology are seen in your clinics.
Yeah, so we have our regular divisions, and then every division has their subspecialties. So for an example, for epilepsy, we have an epilepsy pregnancy clinic where I work with
Ah,
maternal fetal medicine to see patients that are pregnant and have epilepsy. And so like that, there are 20 different kind of subspecialty areas that people have identified that they could provide more tailored care, more innovative care. Also, I think you guys know, sometimes we're siloed in our little
Yeah.
yes.
divisions, their departments. And so to bring pharmacy, rehab services, interdisciplinary round, social work, it just helps with patient care because then now we're all on the same page. We all know what the next step is moving forward. And then at OSU, we actually have a lot of patients that come from rural communities. So they're maybe 1 to 3 hours away. And so to come and have all your appointments on the same day and know what you're going to take away from it can be helpful because then you don't have to come 5 different times and make 5 different trips. So
Oh, yes. That's
Wow.
incredible. I love
I've
that
never
effort for
heard,
the patient.
yeah, I've never heard of this much subdivision in the department.
Very tailored, like you were saying, to each person and their situation. What a huge deal to get these patients treatment. And I imagine as a pregnant person with seizures, how hard would it be to find someone who really knew what they were doing from a multidisciplinary approach to be able to be seen? That's incredible that you guys have those kinds of resources.
yeah, it's
Cool.
been really rewarding because even in your own clinics, you find general themes that happen again and again. And a lot of our patients, especially that have epilepsy and are pregnant, sometimes they come into my clinic and they're apologizing or they're like, I'm so sorry you're
Oh.
pregnant because the stigma is still there.
Mhm.
They still don't think that they can get pregnant or they should not have gotten pregnant. Sometimes they stop all their anti-seizure medications because we just need to get the knowledge out for our patients, and 50% of pregnancies are unplanned. So
Yes.
you have to have the knowledge beforehand, and a lot of times we don't know we're pregnant until well into the first trimester.
Yes, that is so true. Oh, what a wonderful thing you guys are doing for people over there. That's so cool.
Yeah, I was always interested in epilepsy, but as I started practicing, I just realized that I felt like women with epilepsy and a lot of people with epilepsy, but specifically women with epilepsy had many stigmas related to them. And being a
Mhm.
woman myself, I really wanted to help move the needle on that. That was really important
Sure.
to me. I also feel like information often gets bottlenecked. So I go to an epilepsy conference every year. We all meet, we all talk about the nuances of X, Y, and Z. And then we're not distributing the information out well
Yeah.
enough.
Yeah.
And so the big thing is how do we get that information to our community care providers, our
Mm.
patients? They can't stop with us. We can't see every single patient. So we need to get the general information out there. It's so important.
Mhm.
And so I essentially wanted to build clinics where people didn't feel like I was taking away their patient because I never want anyone to feel like
Yeah.
I'm taking away their care. I'm sure they provide great care, but it is a scarier time when you're pregnant. And so my goal was just to take care of patients while they were pregnant, get them through their pregnancy, and then send them back to the provider that they've always known. And
Mm.
so that's what it focuses on mainly. This epilepsy pregnancy clinic, we have 4 different visits when you're pregnant: a first trimester, second trimester, third trimester, and postpartum visit. We do a lot of counseling. We have to monitor a lot of blood work. And a lot of it is just navigating questions about what's going to happen after I have baby and
Yeah.
breastfeeding and all of those things that pop up. So that's been around since I've been here. So maybe 6 to 7 years this clinic started. But now we're starting a preconception epilepsy clinic, which I'm really excited
Ah.
about. It's going to be run by our pharmacist. And essentially, patients, this is a standard that every patient should be counseled on preconception or oral contraception at least once a year. And like you have a million things to talk about in one appointment, you have 30 minutes of
Yeah.
like
Yeah.
so this is allowing us to refer to the pharmacist so that they can look at the medications, look to see what interacts with the medications, what's going to be most effective, give them counseling on major congenital malformations, and then
Mm.
also do a referral to OB. So that's like the setup that we hope to start in February. So that's the other
Wow.
point of it.
That seems to be the key, especially I don't know anything having to do with pharmaceuticals for seizures and pregnancy as that comes together, but I feel like that would be such a major thing, especially for new moms worrying about birth defects, side effects during pregnancy, which already can be really hard. It seems like the key to setting up a good and healthy pregnancy as someone who has epilepsy would be in this very thing that you're starting. So I love to hear that's something that you're passionate about and you're doing. So I love also what you said about the trickle down effect of all the great information that you and your colleagues are compiling at these conferences and the ideas that you're coming up with. As it pertains to the preconception visit, what is something you want to trickle down through this podcast to our listeners? What are some of the most important things for them to know if they're going into a pregnancy with epilepsy?
If you're going into a pregnancy with epilepsy, I think the most important thing to know is that you're going to be fine.
Yeah.
It's all going to be good.
I love that.
That's
Yeah,
reassuring.
reassurance.
Yeah.
Yeah.
But in general, the majority of the anti-seizure medications are going to be very safe to be pregnant on.
Mhm.
And what I mean by very safe is there are tiers. There are some anti-seizure medications that are more safe to be on and some that are much less safe to be on. And those are conversations if you could have today with your provider. I really encourage you to, even if you want to get pregnant in 5 years, just ask them what the percentages are, what the data is on it. And if you don't like what you hear, ask to make a change. And if it can't be done, it can't be done, but at least you tried. But typically, 90% of patients that are seizure free the 9 months leading up to pregnancy will be seizure free during their pregnancy. And that's very
Mm.
consistent. How many seizures before pregnancy you will have during pregnancy? And so, if you can get yourself to a good seizure, then you'll probably do really well during your pregnancy.
Uh,
And a lot of safer medications, they do increase major congenital malformations. So that's like a cleft palate or maybe a heart abnormality, but it's actually only by a tiny bit. So like 2% is the average population. With some of our anti-seizure medications, it really just increases to 3 to 4%. It's very similar to
mm.
that average person. And so I think a few things to do would be reassuring yourself it's going to be okay and you're going to figure out a plan. The
Yeah.
second thing is do not switch your medications before talking to a provider. You should never take yourself off of medication because you don't want to have a breakthrough seizure because that can lead to so many more complications as well. Not just for baby, but for you as well. You have to be safe to have a safe pregnancy. And then the other thing is to really just dig deep and ask questions. And it's okay to ask many questions and be very vigilant about what you want answered. And if you feel like you're not getting your answers, then ask to be referred to a specialist. But I think knowledge is power. I've always believed that. And the more knowledge you can have, the better decisions you can make for yourself.
Yes, and it sounds like those 9 months prior to getting pregnant or controlling your seizures during that time is really key to maintaining control during your pregnancy. Does that sound about right?
Yeah,
Yeah.
absolutely. So we can do the hard work up front to really find the right anti-seizure medication combination. And you go the 9 months, it is likely that you are going to do really well.
Oh, that's
Yeah.
great
So the
news.
management starts way before conception. You got to be on the
Yeah.
right medications that are controlling seizures at the same time, not having very high rates of fetal malformations like some of the older medications.
Mm.
Exactly. And that's why preconception planning is so important too, like
Yes.
contraception. 'Cause if you're not trying to get pregnant, and a lot of our anti-seizure medications interact with birth control and they make birth control less effective. So you might be
Mm.
thinking you're preventing pregnancy, but you're actually not. We only have a lot of pregnancy data on Keppra, Lamictal, and oxcarbazepine, which are
Mm.
3 different medications. The rest, we actually don't have enough numbers to like tell you for sure one
Wow.
way or the other. We know some medications are potentially not great, like Depakote or
Mm.
Topomat. So a lot of them land in this like gray kind of zone. And in the States, we have the North American Pregnancy Registry. So I encourage anyone that gets pregnant to join the North American Pregnancy Registry. What they do is they call you during your pregnancy and after, and they survey for major congenital malformations. And that's how we get our data. So the more people that are calling in and updating, the more numbers we have.
Mm.
But aside from that, I think what we talked about, it's getting yourself into the space where you can be as seizure free as possible. Sometimes seizure freedom is not possible for everyone,
Mm.
but getting yourself to a space where your seizures are not affecting your quality of life, because it is likely that is going to keep you seizure free during your pregnancy.
What other things women can do pre-conception period to reduce the risk of fetal malformations?
The other thing is I encourage anyone that's of childbearing age and on an anti-epileptic or anti-seizure medication to be on folic acid.
Mm.
So in studies, folic acid has shown to improve neurodevelopment outcomes, and it's a very easy thing to take. So we encourage everyone to be on some amount of folic acid. And then other than that, it's really just, I think, really communicating with your provider, like, these are my goals. This is what I would like to do. In 2 years, I would like to get pregnant. I think sometimes reproduction, sex, menstrual cycle, those are uncomfortable topics maybe for some people to bring up. And so it might be that you have to bring those up to get the conversation rolling.
Sure, absolutely.
We have been using a lot of epilepsy surgeries and implanted devices and all that. If uh, someone is a candidate for such a implant or a surgery, should it be considered?
Yeah, so I think the current recommendations are if you have difficult to treat epilepsy or what we call intractable epilepsy, it needs to go down the route of treating someone with intractable epilepsy, meaning that if it's medications, if it's a device, if it's surgery, those things really need to be targeted first. Again, if you're having seizures that are bad all throughout your pregnancy, it's not safe for anyone, honestly. Ideally, we go along and do exactly what we needed to do right from the beginning. Now, if you're pregnant, those are obviously things we can't pursue anymore.
Right.
Can't do surgery. We can't do device therapy. Then we're more of a waiting game, and we do have to monitor a lot of lab work and make sure your anti-seizure medication levels stay stable and things like that. But we can't do any intervention.
So, have you ever seen a patient in your clinic that developed epilepsy during pregnancy but had never had any prior seizures?
Yeah, I mean, if I don't know that pregnancy triggered it. I think it was maybe
It
luck
was
of the
like
draw a
cooking
little
anyway.
bit.
Yeah.
Or maybe a
Yeah, I just
secondary complication during pregnancy, some hypercoagulable state, who knows, stroke, venous sinus thrombosis.
yeah, so
And
definitely you can get symptomatic epilepsy, meaning like something got injured in your brain, and
yes,
now because of that, you've developed epilepsy. More idiopathic epilepsy, or like epilepsy where we don't know the reason. I definitely have had a handful of patients that have developed or had their first seizure during pregnancy, and there's no real reason for it. But 1 in 26 people have epilepsy. So in general, it's common. So it's not,
wow,
unfortunately, it doesn't matter where you are in your life, how old you are, what you're doing. It can definitely just happen, pop up.
Mm.
I think if you have your first seizure during pregnancy or get diagnosed with epilepsy during your pregnancy, it's important that you still get the workup. I think sometimes there's a misconception that you wait to get the workup until after pregnancy, but so important you get your EEG, you get your MRI, we make sure that there's not anything in the brain that's potentially inciting the seizure.
That makes sense. Now, if someone does have a seizure when they're pregnant, what is the consequence, if any, to the baby?
It can be different based on the type of seizures. For instance, someone that has what we call like the old way of saying it was a grand mal seizure, and the newer way is generalized tonic-clonic seizure, basically where you fall to the ground, you stiffen up, and you
Yeah.
shake all over. Those are the most intense seizures because they can create a lot of injury, especially during pregnancy. And so that trauma in general can lead to miscarriages, placental abruption,
Mm.
preterm labor, things like that. Also, depending on the length of it, it could also lead to hypoxia or decreased
Mm.
oxygen baby. So there's a lot of complications that can happen, not just to baby, but also to mom. I mean, I think
Yeah.
that's an important aspect of it. Mom can get seriously injured even if baby is okay. And when you have a major injury, that could also lead to something even more serious. It's not, if it can be prevented, it is absolutely important too, which is why we're
Yes.
always harping on, let's try to get seizure free. Let's try to get seizure free
Mm.
because we just want to prevent people from injury.
Yeah. Oh, that absolutely makes sense.
Yeah. Now, what are some of the common fetal malformations or birth defects we are talking about with these medications?
The major, most common one is a cleft palate or like a lip palate. So anything that kind of creates a defect in the face, that is like the most common major congenital malformation. You can also get like heart malformations or urogenital, kidneys, how you urinate, things like that, malformations, but definitely the facial malformations are the highest.
What about cognitive impairment?
Yeah, so that's a really good question. There was a large funded study, it's called the Monid trial. They are doing neuropsychology testing on all the kiddos at certain intervals after their kids. So, like at the age of 2, the age of 6, they pick certain intervals. And in general, patients cognitively tend to do well. There's data that if you're on Depakote, you are likely to have intellectual delay if you're exposed to Depakote in utero. So that would be, again, another reason maybe not to be on that medication. And some patients don't have any issues neurocognitively with some of the safer anti-seizure medications. But a lot of the anti-seizure medications fall back into the gray zone. So we don't know what cognitively happens to kids because we just don't have enough numbers. We don't have enough people getting neuro.
And we definitely can't test it in a
Yeah, and it's,
trial. Yeah. That would not be ethical.
so this one trial, they tested neuropsych for kids, but outside of that, if someone seems maybe more neurotypical, you might not be getting.
And that's that North American registry comes
Yes.
useful because they keep track of all this information.
Yes. Observational data. That's
Yeah.
all we
They
got.
just keep track of major congenital malformations. They do not keep track of neurodevelopment.
That's good to know.
So you won't get any neurodevelopment
Okay.
information, but you will get information. And it's real-time information, like they update it every 6 months, so anyone can click on it and look at the percentages.
Yeah,
You just have
for
to
the
know.
listeners, do you have a website that you can go to?
Yeah. So it's aedpregnancyregistry.org/history.
Got it.
And take you to the website, and you can click to like for pregnant women, for providers, medications and other treatments. There's always different ways to navigate through the website.
Okay. Yeah.
That's great.
Other
Thank you for
places.
sharing that. Now, is there anything people can do to prevent seizures? So apart from taking medications, is there any like lifestyle intervention, anything that someone can do at home to prevent seizures besides medication?
Yeah. Number one, take your medication.
Yeah.
So, but don't miss the medication.
Yes.
But yes, there are definitely things that you can do. I think not that there's like been a bunch of studies on this, but just like anecdotally, what I see in my clinic, like it's important to live in moderation per se. So you want to get the appropriate amount of sleep. A lot of people have breakthrough seizures with sleep deprivation. So if you're going to sleep like 4 hours a night, that might lead to a breakthrough seizure that next day. It's important to get 8 hours of sleep a night. Stress can definitely trigger seizures. That's the hardest one, right? I mean, how not possible to say live without stress in your life.
Right.
Yeah.
So I think finding tools to minimize stress is important. And that might not be by extraneous factors. You can't cut the whole world out of your life.
Yeah.
But be counseling, that might be a mood medication, that might be mindfulness, it might be meditation. Those are all important things. It could be exercise. So whatever keeps you grounded and keeps your anxiety, and that's going to be, everyone's going to be very different in that. That is important. Some diet therapies are actually have some data on them that could potentially decrease seizure frequency, specifically the modified Atkins diet and the low glycemic index therapy diet. There's also a harder version of this, which is called the ketogenic diet. It's essentially no carbs, very hard for an adult to follow. So it's more potentially
Are
for
these diets safe though during pregnancy?
during pregnancy. So I've had only one patient that's continued with a modified Atkins diet. The ketogenic diet is not safe. The modified Atkins diet with some flexibilities can be safe for pregnancy.
Mhm.
In general, I think living in potential moderation just can be helpful. Not during pregnancy, probably not drinking alcohol, but if you were to drink alcohol outside of pregnancy, maybe one glass of wine, keeping hydrated. And the one thing about epilepsy, the good and bad thing, is if you have a few seizures, you start to identify maybe your triggers.
Mm.
So it's not fun to have that many seizures, but if you can keep like, what did I do that day? What happened that day? And sometimes people are able to tell me, like, when I get dehydrated, I'm definitely going to have a seizure. And then, so that's the thing we mitigate. That's the thing we
Sure.
fix.
That makes sense. It sounds like there are some things that people can do at home to at least get some semblance of feeling in control. Do you know what I mean? Not just this is something that I have to take a medication for, but hey, if I really dial in some of these lifestyle habits, maybe I can actually make a change in my symptoms.
Absolutely. And I
Yeah.
do think that's instrumental because it's easy to feel out of control when you have seizures.
Yes.
They're predictable.
Yes.
Mm.
Absolutely.
Can you tell us about being on anti-epileptic drug and lactation?
Yeah. Again, in the same Monade study, there was an article that came out about breastfeeding. And essentially, what it has said is that some of the anti-seizure medication that is transferred through breast milk when you're breastfeeding, but that percentage is so much smaller than actually what crosses the placenta during pregnancy. And so generally, it is considered to really encourage people to breastfeed. There are a few exceptions. One big exception is if you're starting someone on a new anti-seizure medication after their delivery, then that baby has not been exposed to that anti-seizure medication. So then that's a question of, do you want to expose someone that has not been exposed to it?
Mm.
And then also neuropsychology testing was done on kids that were breastfed and were on anti-seizure medications, and those were not breastfed and on anti-seizure medications. And generally, they had higher IQs and more development or were more progressed in their development. So there are benefits to breastfeeding, but also being a mom and having gone through it myself, I also think that there's a lot of pressure on it. So I
Yeah.
think you do what you can do and just let the pieces fall into place. And nothing's the right way and nothing's the wrong way. It's just you're trying to keep your baby healthy.
Yeah, absolutely. I know that must be a really hard choice for a lot of moms. Among many
Mhm.
hard choices that we all make as moms in the beginning there. Sadly, that's just one added to the list.
Yeah, exactly. So I actually started this pregnancy clinic before I had a kid. And sometimes 7 years ago, I look back at the advice that I gave and I'm like, I can't believe you know,
That was so unreasonable. They can't-
why am I going to you can no one can accomplish what
Yes. Yeah. I feel everyone's practice changes when they become a parent for sure. You're like, oh, I totally understand what you're going through. I'm not going to ask you to do this laundry list of things that you're absolutely not going to be able to do anyway. Let's just do what we can do and call it spade.
Exactly. It's like very humbling
Yes,
sometimes.
absolutely. It's very all
Yeah.
consuming for sure. So, do you want to tell us a little bit more about seizures in the postpartum period? I know that there's a ton of hormonal changes that happen in our bodies after we give birth. How does that change the likelihood that someone may have a seizure? Again, hopefully, if they're already controlled on their medications, does that change anything? And do you often switch things up for people after they have babies or continue on what they already have been on and with just some close monitoring? Tell me a little bit more about that.
Yeah, so the postpartum period is definitely the first 8 to 12 weeks are the hardest, and that's mainly actually due to sleep deprivation and stress.
Mm-hmm.
The first thing is, as you're going through your pregnancy, a lot of times you metabolize your medication a little bit differently, and so your levels start to drop, and so we monitor those closely. And through your pregnancy, we might increase your medication so that we're keeping your levels steady and so you don't have breakthrough seizures. So then in the post-pregnancy period, like right after you deliver, shortly after, your levels go back down to where they are normally metabolized at. So you have to make these postpartum plans essentially for people where we're saying, okay, you're going to back your medication down this quickly because we don't want people to feel ill on their medication, of course.
Yes.
Sometimes what we do is we leave them on slightly higher doses than their baseline doses, and that we basically are just saying we want to mitigate anything that could potentially happen during their postpartum period. And so that's why I mentioned like we do one postpartum follow-up, and that's the reason why, because
Yeah.
patients are often not on their baseline anti-seizure medication dose. And so that very last appointment, 3 months or whenever one chooses to have that appointment, is okay, are we in a good place? Should we
Yeah.
go back down? And sometimes the answer is yes, and sometimes the answer is no, and that's okay too. But it just gives us some footing on, okay, what's the next best step? And sometimes we have to be on that increased dose. Every baby's very different. Sleep is very different. Stress is very different. Everyone's
Yes.
different. So we just play it by ear at that 3-month visit. But the hope is that you're feeling more like yourself, and then that we can back anti-seizure medication down. The other thing is the sleep deprivation part. That's the hardest part. It's just hard not to be sleep deprived when you have a new baby. So it's trying to get that block of sleep somehow. And when you are breastfeeding or pumping, it complicates the situation a little bit because you're waking up actively every 2 to 3 hours to do one of the two.
Mm-hmm.
And so it's trying to accomplish that very quickly and go back to sleep and have your support system help you. And that is where support system becomes very big. And it doesn't have to be in the middle of the night where people are giving you that break. It's hard to get someone in the middle of the night to be with you. But it could be first thing in the morning, like mom comes over and your mom comes over in the morning. And they're taking care of baby while you get some sleep, or your husband or your partner. And so working on both parts is really important. And then decreasing stress. It's just, there's a lot going on. Like I say, try to keep this like stress-free environment, but
Yes, and you're being tortured by lack of sleep and hormonal changes.
yeah.
Oh,
Exactly.
yes. I mean, what a hard time anyway. And then to add trying to dial in these habits even closer to prevent seizures just puts a little added stress on it, I'm sure. But like you said, it sounds like the need for support is even larger in the postpartum period for epileptic patients.
Absolutely.
Yeah.
And I think if you are having seizures, then it's like we need to just be careful, right? Really be holding baby. We shouldn't be giving baby bath. It's never good to co-sleep with babies. It's obviously like a rule we all learn about, but especially when you have epilepsy, if you had a seizure, you could roll over your baby. So there's so many things that can happen. Those are all things that we're talking about, and every epilepsy journey is different. Everyone's situation is unique. And so it's just like really talking through what that specific situation is and trying to mitigate anything that we can. We control
Sure.
what we can. The other part, we just, we hope we can cover with the added medication.
Yeah, that makes sense. So it sounds like a lot of what you do focuses on educating and counseling patients. Do you feel like that takes up the majority of your visits?
Yes.
Yeah. Chatting, having a nice chat about, yeah.
Yes. 30 minutes flies by. There's
Oh,
so much
yes.
education, I feel like. And yeah, I just feel like I want to pour all this knowledge on them.
Yeah.
People to just feel they can make all these smart decisions for themselves. And that's truly what I feel like I'm there for. I can make decisions for people, but I'd rather give someone all the information and then we can make a decision together.
Absolutely,
Um,
yes.
It makes you an active person in your care.
Yeah, and that feeling of empowerment, taking control, knowing there are things that you can do to change your outcome. I think that is powerful for people. So I love that.
Like,
It's great. Do you have any resources or organizations that you suggest for people where they can find support or learn about their condition, especially during pregnancy, besides coming to see you at your clinic in Ohio State?
First of all, I think your doctor is going to have a lot of resources. a lot of specialists are going to give you the same information I just talked about. But online resources, there is a nonprofit organization. I'm on the board of the nonprofit organization, but I'm just talking about it because it is good for information. It's called My Epilepsy Story. And essentially, it's a nonprofit organization to help educate women with epilepsy. And so it has different information on pregnancy, on postpartum period and conception, things like that. Also, Epilepsy Foundation is a great resource. So that's more of a national foundation. And then every state has their own epilepsy, like internal state epilepsy. So we have Epilepsy Alliance, but every state is going to have some version of that. And I hope, like, my hope for the future is that we're able to build some type of community for women. And I'm only saying women because that's my passion, but everyone
Yes,
needs it.
no, that's great.
My hope is that some way we can build a community in each state where you really feel supported by learned experiences by other people that have went through similar situations, and also people that have come out on the other end and they're happy and they're healthy. And sometimes you hear a lot of the negative and you don't hear a lot about the positive, and it's a combination. It's all good and some of it's bad. And I think it's important to hear all those stories, and I think it's important to feel supported in your journey.
Yeah, thank you for sharing all of that for our audience. Your information has just been invaluable. We've really enjoyed this conversation, and I know our listeners will too. Thank you so much for creating such a great space for women to be able to come for this really specialized care during a really scary time. What a wonderful thing that you guys have made.
Thank you so much for having me. I really enjoyed it.
Of course. We'll see you next time on the Neurology Nook. Thank you to our listeners.